Welcome to everybody to the first action period call for Wave 4 of the Injury Prevention Plus Seek program. Very excited to start off the action period calls and welcome all of you to Wave 4. The action period calls for this program will be informational and educational. They will occur on the last Wednesdays of the month during September and October, and because of the holiday on November 30th. Meeting invitations to follow if you haven't received one already. And in the spirit of back to school, we're going to start today's session with taking attendance in the chat and with a quiz. But first, I want to thank our program partner, the Ohio Department of Health, the Violence and Injury Prevention Section, or VIPS. And quick look at the agenda. We'll take attendance in the quiz. We'll have a data summary from Zainab, our data analyst, a great presentation on firearms and youth from one of our medical directors, Dr. Denney. Look at the QI toolbox, some reminders of actions coming up within the program. Plug for our annual meeting and any questions that you may have. Regarding questions, you are welcome to unmute and ask questions throughout the presentation or any of the slides today. You are also welcome to put any questions you have in the chat and we'll be monitoring that. Okay, I'm going to launch a quiz while you guys are putting your attendance in the chat. This is a quiz that we will look at before and after the presentation on firearm safety today. So we want to check our knowledge base before and after. Okay, you should see 3 questions on your screen. Give about 20 more seconds to take the quiz. Okay, thank you for your participation there. Zainab, I will throw it to you for a summary of our data that has come in so far.
Thanks, Brooke. I'm going to take the screen away from you for just a second, and I'm going to display these slides. Please let me know if you can see them correctly. It says you've disabled participant screen sharing.
Okay. How about now?
Okay. Okay, can you see them?
I cannot.
Okay.
I have stopped my share.
Okay. Okay.
Looks
Can you
good.
see them now?
Yep.
Okay, great. Okay, so this first slide, I'm sorry for the technical difficulties. Okay, so this first slide just goes over some of the pre-work survey results. I looked at the results there and I tried to pinpoint a few of the areas where some of the physicians that filled out the survey felt a little bit uncomfortable or they felt like they didn't have enough experience. And so These three points are where the majority said that they had some difficulty or they had little to no experience. And so for the first one, interpreting run charts, when I'm not sure about the progression of how, you know, the data will be displayed to you all, but if we do end up, you know, creating run charts, then, you know, during that time, I'd be more than glad to walk over or, you know, to kind of give you a little bit more details about that and for us to walk through it together as a team, or if you would like to do that individually, we can also do that as well. Some of you also indicated that you are having some difficulty or not very confident in your Pdsa cycles or developing a sustainability plan. And I know Brooke and Haley are on here and could potentially answer any questions you have regarding that. But just know that, you know, as a team, we're here to help you. And, you know, even if you have trouble with something that's not mentioned here, please feel free to just, you know, reach out to Brooke. And then, you know, if it's a question that I could help with, then she'll probably, you know, loop me in. But if not, we can try and figure it out together. So I don't know, Brooke, if you wanted to mention something about Pdsa cycles or you wanted to wait until the end.
Yeah, a good teaser for what is coming up in the QI toolbox. We have some good information from one of our consultants on Pdsa cycles coming up. Yep.
Okay, that's great. And so we're just going to move forward to the next slide. I have 2 slides prepared for you today. And both of them have the same looking a bar chart. The first one is for birth to 12 months of age. So this data is an accumulation of all the data that was submitted to us by you. So thank you so much for taking the time to do that. Here are the main 5 topics that, you know, we had our baseline survey ask about. And it looks like, you know, from birth to 12 months, it looks like the majority of you are doing very well in terms of home safety, car seat safety, and safe sleep. As you can see here, topic addressed here in the blue bar seems to be pretty high for these 3 topic areas. In terms of resources given, we've spoken to a few practices that have submitted their data, and it looks like the majority of you or some of you that we've spoken to are only giving resources when the patient or the family indicates risk in any of these categories. So this might seem low for now. Hopefully, you know, as we work together, we can increase all of these blue and orange bars. But yeah, so these indicate, you know, resources given. Again, we can go over today, you know, what resources are, you know, what's included within this resources. And so as you can see here, social needs and family needs, it looks like we are seeing a lot of no documentation. So you're not really asking about this, or, you know, you have no documentation in your the records that you're pulling from. So we're hoping to, as we progress through the QI months, to see increases in these 2 blue bars for social needs and family needs. But overall, I think here you're doing pretty well. And we hope to see, you know, how these increase as we move forward. And so here is our next slide, and this is for 13 months to 5 years of age. We are seeing a little bit of a decrease with car seat safety and safe sleep. Maybe, you know, physicians or practices might have had something in place for safe sleep for the younger babies and children. And, you know, as they grow a little older, then you might start dropping those questions. But here you can see, again, home safety, like tobacco exposure and stuff like that, are, you know, you guys are doing very well here. Again, here with family needs and social needs, we are seeing lower blue bars. And again, as we progress through the project, we hope to see increases in that as well. And then again, in terms of resources provided or resources given, it looks like, you know, some of you are just giving resources when the patient indicates that there's a risk in family needs or that they needed help with something within this tab. But as we continue on through today's presentation, I think Brooke will touch a little bit on, what resources, what we mean by resources, and as we move forward through the project, what that should include. So if anyone has any questions, please don't hesitate to ask. And if you think of something later, please, email me or email Brooke, and she can forward that on to me. But this is what I had prepared for today. Thank you so much for, sending your data. And if you're still having trouble, with the baseline survey, please contact any of us. I know we're still missing some data here and there. So if you're having trouble with that, please don't struggle alone. Just let us know and we can help you there. So I can pass it back on to Brooke. And I'll also share these slides with her. So if any of you are interested in them, I'll share them with her and she can forward that to you as well.
Yes, Zainab, thank you so much. Yeah, any questions that you think of today, please don't hesitate to ask, but we can also answer your questions around your individual data submissions when you schedule the practice coaching calls. So we get the team together to schedule a call that during a time that's most convenient for you. And we look at the group data and your data individually and answer any questions that you have. So if you haven't scheduled a call with me and the team yet, please email me with some good times and we will get that set up. Okay, next we're going to hear from one of our medical directors, Dr. Sarah Denney. She works as an attending physician in the Division of Pediatric Primary Care at Nationwide Children's Hospital and is an associate professor of pediatrics at The Ohio State University School of Medicine. She is co-chair for the Injury, Violence, and Poison Prevention for the Ohio chapter of the American of Pediatrics. And as I said before, she is one of 2 medical directors on the Injury Prevention plus Seek program. And Dr. Denney, I'll pass it to you.
Great, thanks, Brooke. Hi, everyone. Thanks for joining us today. I promise you won't have to hear me talk every single time that you join us. I know I was on the learning session and this action period call, but don't worry, there will be a diverse amount of speakers. Next slide, please. Next slide. Okay, so I think we went over this during the learning session, but just a reminder as to why we're doing this so we can kind of keep our mission focused on what's important and why we're doing this QI work and why we're doing this data entry and trying to get buy-in from the whole team. But when we're looking at the leading causes of death in US children, in kids 1 through 24, unintentional injury still remains the leading cause of death. So addressing injury is incredibly important, and sometimes during busy visits, it falls by the wayside. So we want to be talking a little bit about that. We also know that physicians are really good about talking about things they're comfortable with, but aren't so good about talking about things that they are uncomfortable with. So hopefully after today, you'll feel a little bit more comfortable having some of these conversations. Next slide. Okay, so this data is probably not surprising to anybody on this call, but the United States really leads the world in firearm death rates by intent. And you can see, unintentional, which is predominantly what we see in this particular age group of this learning collaborative in the 0 to 5 or the 1 to 5 year olds, and then suicide and homicide. So in our other learning collaborative that we just kicked off yesterday, that's more focused on our adolescents and suicide prevention. Next slide. This just came out in the New England Journal of Medicine, and I think that this really helps frame our discussion today. But for the first time in the last 20 years, firearm-related injury has surpassed motor vehicle crashes as the leading cause of death among children and adolescents in the United States. So that's what we're going to spend our time talking about today. Next slide, please. Okay, so the reality is that children commonly live in environments where there is a gun present. And if they don't live in that environment, they are most likely spending time in that environment. Next slide. So, this next bullet point actually is up for debate. This says children as young as 3 years of age have the ability to fire guns. There are some studies that actually say it's down to 2. So, really that 2-year visit's a great time to start having this conversation. The kids are mobile, they're strong enough to pull a gun, they're super curious, they're fast. So that's a really great time to start having that discussion if you haven't already. Next slide. So, little children are curious, big children are impulsive. So for our big children, our adolescents, we're really focusing on barriers to reduce access to lethal means. But in our younger kids, we're talking about safe storage of firearms so that those curious kiddos do not find the guns. I had the fortunate opportunity to train under 2 injury prevention world experts when I was in residency at Seattle. And my attending used to say, Sarah, did you ever find the Christmas gifts? And I'd say, yeah, every year my sisters and I would search the house when my parents were out of town. We'd always find the Christmas gifts. And she said, kids are the same way with a gun. They will find the gun, no matter how clever a parent thinks they are with their hiding places, the kid will find the gun. And so, one thing when I'm having this conversation is I am really clear when I'm talking about what safe storage means, because safe to me and safe to someone else may not be the same. Under the mattress or in the nightstand, someone may think is safe, whereas to me, I do not think that is safe. And so being very explicit in what we're trying to teach is important. Next slide, please. So the reality is over half of all homes have guns. Majority of these are handguns, but of course, all of this varies on where you live. If you have a practice in a more rural setting, it may be long guns are more common. So obviously we don't want to make any assumptions. In Ohio, 37% of households report a gun. My guess is that's an underestimation because not everyone wants to report that. But of those people, 46% reported that their gun was in an unlocked location. Next slide. So this is just some more data that really actually is just a summary of that initial slide that I showed you. So we can move on to the next slide. So when we look at high income countries around the world, the United States accounts for 91% of children killed by guns. This is not news to you. You know this is a problem in our country. This is just kind of giving a little context for you to understand how big of a problem it is. Next slide, please. Okay, so who is at the greatest risk? This was on your quiz. Boys make up 82% of all firearm deaths. African-American boys are 10 times more likely to die from homicide, and white and American Indian youth are more likely to die of suicide by firearm. Next slide, please. Now, when we're thinking about young children, so kind of shifting focus back to the population that we're talking about in this particular learning collaborative, when we look at shooting deaths in young children, it's most likely to be intimate partner violence related, bystander related, or family conflict. Next slide. When we look at the accidental shootings in young children, this is most often with the shooter is a young child. I feel like we see these stories on the news all the time, unfortunately. Most commonly involve playing with a gun and most often occur within a home. So these are really the types of deaths that we're trying to prevent by getting that firearm locked up safely. Next slide. Again, just looking at intentionality rates, excuse me, I'm just going to move this. So we're seeing suicide rates going up while we're seeing homicide rates going down. And again, this just speaks to reducing that access to guns. So having those conversations now while the kids are young and getting those guns locked up really helps, and then continuing that dialogue as they move into adolescence. Next slide, please. All right, so we know that of youth who complete suicide by firearm, 82% use the firearm from their home. So if we can get those firearms locked up, we can reduce that access. And household gun access triples the risk of death by suicide. Next slide, please. Okay, so, I'm telling you all these things about guns. And so what works and what doesn't work? I'm going to just kind of review a couple studies who have looked at this because Obviously, we want to make sure that what we're doing is evidence-based and that what we're doing is actually effective. In this particular study, it was done in a predominantly Hispanic population. There were two different groups. There was one in which gun safety counseling and written safety information were given, and then one where a gun lock was also given. Of the intervention group where the gun lock was given, so counseling only, and then counseling with written and gun lock provided. Of the group that was given kind of the more intense counseling and storage, they saw 61% change in that intervention group, where either guns were removed or there was improved storage practices within the home, whereas only 27% in that control group that just received the counseling. Next slide, please. Okay, what doesn't work is gun avoidance programs. And I'm going to go over some data in a minute to kind of just reinforce this, but I hear all the time people say, well, my kid was raised around guns. They know all about gun safety. So like, this doesn't apply to me. It doesn't matter, especially when we're talking more about the adolescents, because that impulsivity, that immature frontal lobe. But we know that gun avoidance programs alone don't work. Next slide. So in this particular study, the authors took kids and they recruited kid and parent dyads and then separated the groups and asked them questions about gun safety. And so they would ask kids, like, is there a gun in your home? Do you know where it is? Have you touched it? And then they asked the parent separately, does your kid know where the gun is? Does your kid know there's a gun in the home? Has your kid ever touched it? And so then I'm going to just kind of go over the results. So kids as young as 10 were just as likely as older kids to have known where the gun was held and to have handled it. Over 40% or almost 40% of parents incorrectly thought that their child did not know the location, and 22% incorrectly thought that the child had never handled a gun. And this has been repeated in so many studies where, they have kids in like a mock-up bedroom and there's a gun hidden. And even though every single child in the room has had some sort of gun safety class, like some kid always goes and picks up the gun and then points it at someone else. And so we know that safety alone is not adequate. That's why we need the safe storage. Next slide, please. So what do parents want to know from us? This is kind of a follow-up to the study that we were talking about during the learning session with the focus groups. And when the study investigators asked parents about what they want to know from us, the people that responded said they want to know when we should start talking about firearm safety, how to discuss it, and then also how to discuss it with the parents of kids that your child may be going to play with or going to spend time in that home. Next slide. Okay, and then when in that same study with the focus groups, parents did say that when asked about gun-related topics, that they might not understand why pediatricians are talking about that, but they also said that they do want to hear these messages from their pediatrician, but the attitude and the delivery and the lack of not being judgmental was really, really critical in how those conversations are held. And then they offered some advice on how to communicate parenting messages. Go ahead. Okay. So, very similar to the talking points that we use in our Store It Safe materials for providers is, in many places or many people, gun ownership is normative. And we saw the data from Ohio, right? Like you can pretty much assume at least half the people in Ohio have a gun. And so making it not asked in a way that is at all judgmental is really helpful. Parents also felt that the pediatrician would not be able to convince them to get the guns out of the home. And I think that, the national AAP policy statement says the safest home is the home without a gun. And that may be true. I mean, obviously it's true. The data supports that that's true. But if my families feel like they are safer with the gun and I tell them that they should remove the gun from the home, they're not going to remove the gun from the home. What I really want to do is have a really open dialogue about how we can, you keep the gun safe. And I think they're much more likely to do that than to just get rid of their gun. The other thing that this focus group said, which I think is a really important point to remember, is that parents within a family may not agree on this issue. And that can be kind of contentious. But as a follow-up to that point that they made in this study, they also said that they appreciated the physician sort of getting the conversation started when there may be conflict between the parents on this particular issue. Next slide. Okay, so I know that we've talked a little bit about our own experience at Ohio AAP with bringing groups together. And this particular study done by Segi and published in Pediatrics, which I also referenced during our learning session, really just reiterated the same thing that we heard from gun owners. And that was that parents don't want a record of gun ownership. And one of the suggestions from the focus groups was parents said, well, maybe you could talk about it without asking about gun ownership. I really have not been finding that families are upset or offended in any way when I'm talking about gun ownership. Presenting the information in a non-condescending way, I think that goes without saying. And then appreciating written materials as well as a supplemental discussion, especially if you have, one caregiver who's coming to the visit and one parent who's not, or one caregiver who's not, then, it's helpful to have that written. And then people can really varied on their comments about statistics. So I think that's really a personal preference on how your patient families learn and how comfortable you feel with the statistics. Next slide. Okay, so the Partnership for Safety of Children Around Firearms was started by the Ohio AAP, and it was really an opportunity where we brought together people from all sides of this issue. We had parents who were firearm owners, parents who were not, pediatricians who were gun owners, pediatricians who were not, law enforcement, military, concealed carry instructors. We had Buckeye Firearms, sort of like the NRA, but of the Ohio version. And we said, like, what can we agree on? Like, where's some common ground here? Like, we agree that our organizations will never see eye to eye on all issues gun related, but like, what is something we can agree on? And it was around storing it safe. Next slide. And we were really, really intentional about what we were going to talk about. We were not going to bring everyone together and start talking about, the failure of the mental health system or, the Second Amendment, any of this. What we wanted to do was come together and discuss in a non-divisive way, like, what gun safety message can we all agree on? And then once we determine that messaging, could we all start sharing that message and have kind of a tagline, sort of like click it or ticket, but related to guns. Next slide. And we also were very specific with our age group. So we wanted to discuss unintentional firearms related to children, and then the suicide deaths of teens due to firearms. Next slide. Okay, we did not want to talk about Second Amendment and taking guns away. We did not want to talk about a gun registry. We weren't going to take on gang violence at that point in time or mental health issues. Not to say that those all aren't important, but for the focus of this particular group coming together for the first time, we felt like we needed to kind of put some things off limits to try and keep us focused on what we were trying to do. Next slide. And what we learned was there was some distrust of the medical community, that gun owners felt judged, and that there's a very, very real fear that the EMR is also serving as a gun registry. And so that if we're asking about gun ownership, that we're recording it in the EMR and then that data is available. But we also learned that people are very open to conversation and they want to keep their kids safe just the way we want to keep kids safe. And then it's all in how we approach it. Next slide, please. All right, so these are some of the groups that came together. And then next slide. Store it safe was the tagline we came up with. And so our very first phase was focusing on the young children. Next slide. So we developed these handouts. One is for physicians or healthcare providers, just about how do you have this conversation? If it's not something you're comfortable talking about, if you're worried your families are going to feel that you're intruding, like how do you have that discussion? And then we also created a handout for families as well. Next slide. So, you know, people are pretty used to us talking about safety. I feel like during the well-child visit, that's what we do during anticipatory guidance. And so just rolling this into it, just the way we talk about other things like medication storage and car seats, this is a safety issue, just like we talk about swimming lessons and drowning. And then the other thing is just operating under the assumption that everyone has a firearm and frame your discussion that way. So instead of, do you own a firearm or do you own a gun? You could frame it as, if you have a gun, is it kept locked in a safe place? Something like that. And so it's sort of like when we're doing our asthma visits and we're like, do you ever miss your asthma medication? Sort of sounds a little accusing, like, I know you do. You could just say, in a week's time, how often do you think you miss your asthma medication? That sort of normalizes the fact that people are going to miss their asthma medication. And so instead of asking in a judgy way, like, let's just ask it in a way that gives permission to be like, yeah, I do miss it. I miss it probably twice a week. So next slide. Okay, so this is exactly what we just went over. And so if you say, you know, if there's a gun in the home, is it kept locked up? And they say, yep, I do have a gun. It's locked. You know, there's no way my kids can get to it. Okay, that's great. Great opportunity for some positive reinforcement. If they say no, then there's the opportunity for education and a gun box. And then if they say, well, we don't have a gun, so it does, like, we don't need to worry about it. I think it's really important to keep in mind that data about gun ownership. And the fact is the child is still going to be spending time where there's a gun in the home, whether it's at a friend's house, a family member's house, the babysitter's house, who knows? But just being like, well, we don't have a gun, so we don't need to talk about that, is not going to keep that child safe if they're in that situation. Next slide. Okay, so, you know, out of this partnership, all of a sudden we started getting money coming to us, and people were like, hey, like, we want to see where this project goes. So through the funding from the Ohio AAP Foundation, Buckeye Firearms, and Kiwanis, we decided to run a pilot project in which we were going to give the family handout that we created on gun safety at every 2 and 3 year well-child visit. We're also going to offer a gun box to families at this time. And then every family at the 2 and 3 year well-child visit was going to get a survey at the end, whether they took a gun box or not. Next slide. And, you know, keeping in mind that we only had one message, right? The message just was, if you have a gun, keep it locked up. That was it. So when we asked the question, did someone talk to you about gun safety and safe storage today, or give you a paper about it? 94% said yes. So that was helpful information, like our message was getting out there. Next slide. But this one was shocking to me. Did you learn something new about gun safety at your visit today? Again, the only thing we're teaching is store it safe. And 50% of people said, yes, I learned something new about gun safety. Next slide. Of the people surveyed, 61% took a gun box. Next slide. And so then we had some questions about, if you did take a gun box, what were you going to use it for? And if you didn't take a gun box, why not? So the gun boxes we provided, and I'll show you a picture of them at the end, also had a cable. So you could use them either in your house, or you could also cable them to the seat frame of the car. If you were, you know, carrying your gun and then you were going to go into the school or the hospital and you need to lock it up. So 80% of the people who took one said that that's where they were going to use it. Next slide. Of the people who declined, 84% said they declined because they didn't have a gun, which would make sense. But I thought it was interesting that 3% said I wouldn't use it. And then 7% said it wasn't offered. Next slide. And then just to kind of validate some of the other studies that we've been hearing, we did want to ask, do you want your pediatrician or your healthcare provider to be giving guns, and giving guns, that would not be good. Giving you information on firearm safety, and 48% people said yes. You know, that's where they would prefer, of all the places, they would prefer to hear it from their healthcare provider. Next slide. Okay, so this is a picture of the gun boxes that we provided during our pilot study, and you can see it fits a handgun, which again is helpful But depending on where you are and what kind of guns are most common, a different type of storage would be probably recommended. And then you can see the cable in that bottom box that can be used to help secure it to something. Next slide. I think that's it for me.
Yeah, I think that's your last slide, Dr. Denney. Thank you so much for all of that wonderful information. While you guys are thinking of questions to either share in the chat or unmute and tell us about them, I'm going to relaunch the quiz to see if we learned anything. About 20 more seconds, and then I will share the answers. Okay, so the answer to the first question was 37%. Majority got that one right. This answer, about half picked true on the first go round of the quiz, but now we know that boys make up almost 82% of firearm deaths. And answer to this one is 40%. Thank you, Dr. Denney, and thank you all for participating in the quiz. Any questions that you think of, please let us know. Okay, this next set of slides has an audio component. If you cannot hear Ronnie Christopher, our QI consultant, speaking about Pdsa cycles, please let me know.
Hello and welcome to our session on effective Pdsa cycles. This is our rapid learning session for understanding the Plan, Do, Study, Act tests of change. I'm Ronnie Christopher, and let's dive in. So I said the Plan, Do, Study, Act tests of change. What's a test? A test is something that's rapid. It starts small. We're always looking to try something at a very small pace or a very small number so that we can fail fast and recover quickly without having a lot of risk. We start with one thing, one person, one visit, one time. We study it, decide if we're going to continue to ramp up a test, and we go to 2, 5, 10. So we're starting small at the beginning. It's an opportunity for us to learn, and it informs our long-term change, allowing us to sustain things over time. So what makes an effective Pdsa? There are lots and lots of theories on how to manage Pdsas. We can break it down pretty simply. The plan is who does what by when. And one of the most important things to do in the plan part of your Pdsa is to let all the people who are participating in it give a hypothesis. Are they yay or nay for the study? Do they think it'll work or not? When you give everybody an opportunity to have their say, yay or nay, then you have an opportunity to have really robust study when you're completed with the test. The do is counting every little step. This is where you want to make sure you have a robust task list and you know who's doing what by when in terms of the plan. Everybody who has a task to complete knows what their task is. They know when they're getting it done, and they can check it off when it's complete. In the study, we're asking ourselves, what did we learn? Were we surprised? Who got it wrong? Who got it right? What do we need to do next? And in the act, we make a decision. Did we like it? Did we love it? Or did we scrap it? If we like it, we're going to run this test again, maybe with more people, maybe more often. We're going to see if we need to make a few tweaks here or there, and we'll decide after those if we're going to love it. When we love it, this test means that we think this is a good idea. We're going to implement it as a process, policy, or change. If we scrap it, it means it wasn't that great. and we're never going to do it again, we don't have to think about it. So thank you for this time in understanding PDSAs from a rapid learning series perspective. Happy planning, happy testing, happy doing, studying, and acting.
Thank you, Ronnie. Very informative in a very quick way. As Haley said in the chat, anything related to this program at all, especially QI, we can meet separately and talk about it anytime that you guys are available. We'll get the team together. Continuing on our QI toolbox discussion, Zainab teased us a little bit on reviewing the definition of resources when it comes to the purposes of this program. We defined resources as any information provided to the caregivers or patients related to the social determinants of health topics and the injury prevention topics as focuses within this program. Examples of resources are the family resource handout and/or a scan of the QR code that is on top of the family resource handout. And that links directly to the Injury Prevention plus Seek resources page. We are updating that on the regular. That is where the community specific resources will be housed, and any of the recordings around these sessions, for example, will be housed. So that is being updated on the regular, and you can go there at any time. Any in-house resources can be counted toward this program. If you currently use something that you like, please don't stop using those. Please don't hesitate to share those with us and with your colleagues. Cabinet locks can be shared as a resource provided by us during this program. And then a referral to an agency or to another provider. If you do this today, please keep doing so. And we have had some fun technology questions come in from participants who have started using the iPads and the technology on the iPad so far. Want to see how that is going? We can ask questions here, or we can have the one-on-one chat anytime that you are available. And just an FYI, the recent Apple security issue, it came out in the news last week. Their issue does not impact the iPads that you are using for this program. So we were able to kind of skirt that issue based on the age and the version of the iPads you are using. So you don't have to worry about any of that during this program. And just reminders, I will send these out via email as well, but the pre-work and the baseline data is due at the end of the month. As well as any of the webinar recordings or learning session recordings that you have missed. You could brush up on those by the end of August as well. And then hopefully you are feeling okay about submitting your first Pdsa cycle worksheet. That is also due on the 31st. Working on the screening tool data collection with the iPads or with the website. That's kind of an ongoing thing throughout the program. The schedule, your practice coaching call, any questions that you have, we can answer one-on-one. Schedule those by September 27th, if you would, please. A reminder that the second action period call is September 28th. Sadly, it won't be Dr. Denney speaking on that one, but we've appreciated her knowledge so far. And then that's the last call for any interested colleagues that you may have to enroll in this wave of the program. And a plug for our annual meeting. AAP annual meeting is back. We are very excited to be hosting in person. And fun for you, it is free for Seek participants. So it'll be held October 28th and 29th at the Polaris Hilton Columbus. We're using an innovative approach to learning this time. We are inviting all participants that are currently in QI projects and programs to join as part of a larger session of networking. I think this is a great idea, and it should go really well, and you can meet your colleagues and talk about your experiences in the program so far. And we're excited to have a nationally known speaker talking about Black maternal health. Dr. Major Kincaid's topic will be racial disparities in healthcare and improving Black maternal health outcomes. Very excited to hear her speak on the 28th of October. And you can go to our website around our annual meeting to learn more about this, and you can also register there. So free registration for you under current Ohio AAP member or staff. Very exciting. Okay, a lot of information today, a lot of good information. Does anybody have any questions to share? If you don't feel comfortable sharing today, you can email me at any time. But if you ask something around this program, someone else may have the same question. Okay. Hearing none, and in the interest of time, thank you so much for attending today. I will be in touch and we will speak soon. Thank you so much.